So the complexity of care of the emergency patients that we see here was vastly different than what we would see in rural America. A lot of times it's, orthopedic, fall down, break your arm, put them in a splint. You call whoever's on for orthopedics, get them an appointment the next day. If it's really bad, the orthopedic doc will come in, take care of that. That's a majority. Or small lacerations that need to be sewn up, things along that. Every now and then something serious would happen, but they'd be transferred out very quickly.
Gotcha. Thank you, Dr. Gunnerson, for joining us today. Would you mind just briefly introducing yourself for our viewers before we get into it?
Yes, thank you, Harvin. My name's Kyle Gunnerson. I'm an emergency medicine and ICU physician here at the University of Michigan.
Excellent. So take me back to where this all started. Where did your interest in medicine begin?
Oh, wow. So that goes back quite a way. From as long as I can remember, my family have always told me I was, interested in, saying I wanted to be a doc. I remember I was probably, 6, 7 years old having this conversation with my dad. And he said, "What do you want to be?" And I said, "Oh, I don't know, maybe an astronaut or a baseball player or a doctor." Those sound like, the three hardest things to do.
And you picked doctor?
And I ended up becoming a doc, yeah. I grew up on a farm in Kansas. And so there aren't too many astronauts coming from farmland Kansas. I still wanted to be a baseball player, but, sometime in life you realize you're not good enough, and that happened pretty early. And so the last thing on the list, was a doc.
Did you have any doctors in your family? Did you know anyone that was already doing it?
No doctors in the family. I was really in the immediate family. I was the first one actually who finished college.
Okay, wow, excellent. So take me through what your high school and college was like. How did you sort of start to explore this field?
Yeah, so it's a lot of these things like when you're young, you see maybe on TV, or you see with your, exposure to, a family friend or your family doc or a fireman, or, some tragedy, you get exposure to that as a profession, and it makes an impression, and you explore that, but you have no idea really what's happening. And like I said, I didn't really have anybody in my family other than my family doc, who wasn't family, to ask these types of questions. So it was an ideal based on just, a lot of, esoterical type of information. As I went through high school, it was a very rural, consolidated high school, not too dissimilar from rural of America, here in Michigan. Did the typical sports, every activity. Went into the local college because I got a full ride, to save some money. Still thinking going into med school. And towards the end of my high school and into my collegiate career, it really started to solidify. I think one of the more impressionable classes I took was taught by an old paramedic who was in the Korean War and would, describing, physiology and anatomy, would show some very gory, detailed experiences that he had during this, which would gross out, half the class, but the other half was either asleep. And there was a few of us that actually really, dug into it and enjoyed it. And then we also had a field trip to a local college to had a cadaver, and we had a dissection that we were able to experience, which was pretty unique for a high school student. And that again solidified right there that this was something in this field that I wanted to explore.
And so now that you're well into your practice as an attending physician, would you say that medicine now is what you thought it was back then?
Oh no, it's nothing like what I thought growing up and what I thought medicine was going to be like. And the one thing I can 100% be sure of to give advice is that 30 years into your career will not look like what you thought your career was going to be when you're standing, or in that lecture hall, being welcomed into School of Medicine, wherever you end up going. I guarantee you it will be different. I thought I was going to go back to Kansas, and there were no residency trained board certified EM physicians in Kansas at the time. There was actually there was a small group of 4, and where I lived, and they all left after a few years. So I was fortunate to be exposed to them, but I also knew the landscape. And it was all family practice, all internal medicine, and then general surgery who did the majority of even the big cases. And then you had a few specialists, just because it's rural America. They didn't have the specialists that you do in the big cities. So I thought I was going to go back to that area. Through my undergrad, I volunteered, and then I ended up working at our local hospital in the emergency department and also in the ICU as a monitor tech, watching all the electrical, the ECG monitors and stuffing charts. That's back when we used to write notes, with pen and ink, on paper.
The world's changed. Yeah.
Yeah, so I had to stuff the charts, make all the charts, make sure the coffee was ready for the docs in the morning.
Okay.
And so I got exposed to emergency medicine and critical care. And I went into med school, thinking that I was going to probably take something along that path. And then as med school kind of evolved, I started getting more, I liked everything, but I knew I wasn't going to be a surgeon, which is the biggest fork in the road that you have to make as a med student early on. Do you like the operating room or not? I liked it, but I didn't live for it. And so that was my classmates who just lived and died couldn't stop talking about it. They all went into surgical specialties or anesthesia. And then those of us who didn't, we went into other non-surgical specialties. I knew I wasn't going to be a surgeon. So then it was what was I going to do? I wanted to come back to Kansas, no ER docs. So I did a combined internal medicine, emergency medicine residency at Henry Ford Hospital in downtown Detroit, thinking that if I have both of those specialties, at least when I come back home, they'll know what an internal medicine doc is, and I wouldn't have to explain myself all the time. That was my idea. That's what I thought I was going to do. So didn't turn out that way.
Yeah. So quick question: if there weren't any ER docs in that rural area, how did they manage emergencies when they happened?
Yeah, a lot of times it's similar to what it is now in rural America. There's just not still a lot of enough board certified residency trained EM docs to go around to all the hospitals. So what would happen, you'd have a family physician that would be taking call if it's a really small hospital, and then somebody came in that needed emergency treatment, they'd call the doc that's on call. They would they had to live within a few minutes of the hospital. They'd drive in, take care of whatever the emergency was. Bigger hospitals would have staff. You'd have a family medicine doc for maybe that week, or maybe even hired as an emergency medicine doc. And they have, each hospital has different credentials, so they'd probably have to have a combination of pediatric advanced life support, adult cardiac life support, some type of trauma life support training just to get a patient stabilized. All these merit badges, we call them. And then they would be able to staff the emergency department. But they weren't trained in that primarily. They were trained either in family medicine usually or internal medicine.
So there is definitely a discrepancy in the level of care you'd receive over there compared to here at U of M, for example?
Yes, there is. So the complexity of care of the emergency patients that we see here was vastly different than what we would see in rural America. A lot of times it's orthopedic, fall down, break your arm, put them in a splint. You call whoever's on for orthopedics, get them an appointment the next day. If it's really bad, the orthopedic doc will come in, take care of that. That's a majority. Or small lacerations that need to be sewn up, things along that. Every now and then something serious would happen, but they'd be transferred out very quickly.
Gotcha. So obviously in med school, you have to sort of figure out what kind of doctor you want to be. That's a big decision, right? How did you decide that you were drawn to this side of medicine? Because sometimes people say, you have to choose what you're passionate in. Other people say do what you're good at, right? So what drew you to this side of, this side of the spectrum?
Yeah, that's a good question. So when you start your clinical years, now when I went through in the early 90s, it was very, very cut and dry. The first 2 years, almost no clinical experience at all until the second half of your second year. very, very little clinical experience, a lot different than what it is today in most med schools. And so you really didn't have much of an exposure until your third year. And you really need to start applying to residencies starting your fourth year, so you can get interviews underway, especially the very competitive ones. So you don't have much to cram in, the field of medicine in 1 year, especially when the core rotations take several months. So that's a very good question. A lot of times you'll see students who've had previous exposure in certain fields because of family, they're a legacy, cardiologist, so to speak. I had several in my class like that with, whatever specialty they have come from, and they knew they're going to be third generation urologists. I wasn't like that. So like a lot of us, you have to make this up very quickly. And that kind of depends on what your rotations are as a third year. So if you're able to get an ophthalmology rotation in your third year, and as your one elective, and you love it, then you may have an opportunity to pursue that. But if you don't, you really have no idea other than if you saw one when you're getting glasses as a kid. So as I was going through, I liked everything, and I think a lot of us at that time, because we were so starving for actual medicine, we've had biochem up, as high as you can get it. We've had pathology out of all this stuff, and it's time to actually see patients. That's why we're into this. And so I liked everything. And I think that part of it was gearing me more towards the thinking, non-surgical, non-procedural type of field rather than a surgical. And again, that's the surgical part I emphasized. I know you'll talk to some surgeons here and anesthesiologists, but they, a lot of the ones that I know, almost everyone that I know, they just have this feeling. They just have to live. They live for the operating room. If you don't have that, in my experience as a non-surgeon, then it's a long, grueling field in training and as a profession. It's going to be a struggle. And so I just didn't have that. So that narrowed it down to the other half. And I liked the thought process of internal medicine. I liked the complexity. I also liked the action and the, being able to make a diagnosis on critically ill patients early. And that's where emergency medicine came in at the time, a little mix of everything. So for me, the combination of both made sense to do internal medicine and emergency medicine.
So often people have to choose between the two. It's interesting that you had, both perspectives.
Right. And, in jest, we all kind of make fun of each other, and every specialty kind of, roasts each other in fun. But the internal medicine and emergency medicine have quite different, thinking styles. One is more, very quick, there's limited differential, get the patients to where they need to be in emergency medicine. Stereotypes, of course. And then internal medicine is more of the thinking, take your time, again, which wouldn't really work well in an emergency department that has 50 people in the waiting room and another, 50 people waiting to be admitted. And so to do both, I actually just took bits and pieces of both of those that I, have built my practice on over the last 20 years. And I think it's made me a little bit better doc by able to take the best of both worlds in that.
So what was your residency like?
So residency was wonderful in its difficulty and experiencing new things every day. It was 5 years. You make some of your best friends for life in your internship when you're now thrown into this with responsibility that you've never had before. And this was before the 80-hour work week, and so we were working long hours, more than we work now, which wasn't necessarily good, but it puts you through a very long, tiring, traumatic process. My training was fortunate enough to have just the right amount of oversight, so you really felt like you weren't hurting patients by doing things that you just had no guidance with. And it also had a lot of autonomy to where once I graduated to get that more, graduated autonomy role as I progress through the program, I was able to exercise that, earlier than if it was through a more, heavy-handed side of a program.
So were you primarily in the ER, or was it like a mix of like the ER and like inpatient, or?
Yeah, good question. So it was a mix. So I would have 6 months ER-based emergency medicine electives or time in the ED, and that includes various surgical rotations I would round on, plastic surgery, vascular surgery, trauma surgery, etc. And then the other 6 months would be internal medicine based. I'd have clinic, like any other internal medicine, full-time medicine resident. I'd have clinic, I'd have electives based on the internal medicine electives, cardiology, nephrology, rheumatology, etc. And so that, by doing both of those together, some of the electives in each individual one were taken off, and that's where it was condensed to 5 years instead of 3 years times 2 or 6 years for both of those residencies done, individually.
And so in residency, and obviously in medical school, people pick up a lot of mentors along the way. You sort of show them what it's like to be a physician. It sort of teach them important life lessons. Did you have that experience as well?
Yeah, mentorship is very important, and you can have multiple mentors through the stages of your life and your career. And one of my early mentors in medicine, in residency, probably the most influential, was a EM critical care doc still practicing at Henry Ford named Manny Rivers. Manny Rivers did EM/IM at Henry Ford, went to Pittsburgh, did a critical care fellowship, came back, and always in inner city Detroit, some of the patients are very, very sick. They just don't have access to, to health care. And so they would come in presenting with very extremes of common chronic illnesses. So extremely high blood pressure, end-stage renal disease, bad lung disease, asthma that just hasn't been treated. And they would present to the ED at the very last minute and be extremely sick. And Dr. Rivers was both an intensivist, he rounded in the surgical ICU, and as an EM doc. And his view was that we can do more for these patients when we catch them early in the ED than we can do 3 weeks of care in the ICU. We need to identify them early. We need to start treatment right away rather than waiting until they get to the ICU. And that was a big time when sepsis was trying to get a foothold in critical care and medicine. There was a lot of understanding of inflammatory markers, mediators. You started having some criteria. Dr. Bowen out of Chicago came up with criteria to identify what's called SIRS, the Systemic Inflammatory Response Syndrome. That was done in the late 80s, early 90s, about the time that I was now starting off as a med student and then going into residency in 96. Dr. Rivers took that approach and was screening patients right up front when they come into the ED. And if they were sick, he would bring them back to their more monitored area called Category 1. This is where all the monitored patients went in the Henry Ford ED, or Cat 1. And so he'd bring them back there to Cat 1, and we were catching patients that were really sick, were able to compensate for that time, but would have crashed in the next several hours if we wouldn't have intervened. And we definitely, that plan, that strategy made a difference. And it was very, very impactful in my life and a lot of other of my classmates, the residents that went through there, to see how much of a difference we can make on these sick patients. We catch them early. A lot of times it would be triage. If they weren't in cardiac arrest or if they weren't in extremis, they would just go back to the regular part of the ED, and you have no idea. Well, with this type of early strategy, looking at vital signs and then drawing some basic, simple blood work, lactate, we could identify these patients early and bring them back. And so that really, and then we went on. Dr. Rivers authored and did research in the first clinical trial of looking at early goal-directed therapy for sepsis, which started then, and that was published in 2001, New England Journal of Medicine. And then that started this whole new wave of clinically managing sepsis, and all the different strategies that we have now was kind of based off that that early intervention paradigm that Dr. Rivers came up with. And I just happened to be there as a resident at the time, seeing this unfold before my eyes, enrolling patients, being part of the whole research machine where we just did it ourselves. We'd draw blood work on our patients, we'd spin it down, we'd pipette it off, we'd store samples in the -80 freezer, and got to experience the entire clinical and research part of emergency critical care.
So that concept of acting sooner rather than later, was that novel for that time period in this side of medicine?
Yeah, it was actually. A lot of the sepsis trials at the time didn't enroll patients until they were admitted into the ICU. And even then the entry criteria was, some of them were up to 24 hours after being in the intensive care unit. And so that could be a day after they presented to the emergency department. And what they would receive in the ED would be, so variable, and it could be very minimal compared to what we know now, especially antibiotics and IV fluids, etc. And so, yeah, it was quite novel at the time to do that, bring the ICU down to the ED, so to speak.
And so would you say that that research has sort of changed the path of that field of medicine going forward over the years? Do you think that sort of brought forward a new sort of chapter in terms of, acting before something gets too late?
Oh, absolutely. I think that's affected all aspects of medicine with critically ill patients, surgery fields, as well as, other diseases other than sepsis. It definitely has made a huge impact in sepsis and septic shock. And there have been multiple trials, management trials. We've always tried to find a so-called magic bullet that you give a certain, cytokine blocker or some type of pill that would modulate your either inflammatory system or some process that's getting out of control to see if that would affect mortality. None of that really works so far. We haven't really found that, and probably won't in my lifetime. But what has really brought to the forefront is that we need to early manage these patients clinically based on clinical needs that they are showing, whether that's more IV fluids or less, depending on how they present, but usually it's more than what they present with. Early antibiotics, source control, and then, reassessing to make sure that these steps that you're taking are effective, and if we need to continue resuscitation along those lines. And that's changed the entire way we treat sepsis now, and we've decreased mortality, from a disease that was a mortality over 50% at times in septic shock. That's come down now to, it's still high, it's still anywhere from 20 to 30%, but we've made huge strides in treating that. That early mentality also has transitioned over into the operating room for anesthesiology and resuscitating patients in the OR, and so it's really had its impact, managing heart failure and cardiology patients. So it's had its impact in more fields than just emergency medicine and sepsis.
And so you've obviously been very involved with research in your career. What can you say on the impact of research on your clinical decision making as a physician? So
I took a summer off and worked in a lab and went to the University of Kansas. That's the farm town that I grew up in. I went back and worked in a lab for a summer in a nephrology lab, and had no idea what to do. They showed me how to smash rat kidney cortexes through a little mesh and isolate the glomeruli, and then the processes that were used in the thinking and of how to test glomerular permeability. Something I don't use now at all, but that whole process and going through and working with PhD docs that ran the lab. And then working with postdocs, and then working with nephrologists who this was, they were in fellowship doing this as their project. Seeing that team approach and being the most junior person in that team was just fascinating. And seeing that what a really, truly meticulous, you have to be doing this type of work to get the results that, that are going to be valuable in one way or the other. And so that shone a light the behind the scenes of where we're getting some of the medication, some of the treatments, some of the therapies that we have as a practicing clinician. It really helped, and I enjoyed that, and I did some of that even in my fellowship. But then, as you graduate and you get into the real world, life takes over, and aspirations of becoming a researcher primarily kind of get put on hold as as your clinical career ebbs and flows with the times.
So what was that fellowship experience like?
So after the 5 years at Henry Ford, I followed in Dr. Rivers' footsteps and went to the University of Pittsburgh, and that was phenomenal as well. Again, this was this is all critical care. We are taking care of mostly surgical, really sick surgical patients, a very large liver transplant unit, large cardiovascular units with a lot of heart transplant, lung transplants. ECMO was, the devices used in ECMO was still relatively primitive to what we have now. So the mortality was a little bit different. This is before some of the mortality studies in adults, with influenza and COVID have been published. So different times, able to experience various heart assist devices, LVADs in its infancy. And so it was a great time to be training. Again, it was extremely long hours. The whole hospital felt like it was run by fellows. Residents kind of took a second seat to the fellows, and so I was working hand in hand with all the surgical subspecialty fellows that were there, and we got to be very close because we all were working crazy hours of the night, and every third night call for 2 years. So that was, you build again close friends across specialties. Very, very rewarding. I met lifetime mentors. I still do research and do projects with one of my mentors at Pittsburgh, who does primary acute kidney injury and blood purification in critically ill patients. And we're still very close and talk to him all the time, and we have several projects together 20 years later.
Wow, excellent. So you mentioned that you were obviously working a lot of hours. When you were in the thick of it, did you have any sense of regret or resentment about the fact that you had to put so much time into it? Like, were you aware that you were sacrificing this part of your life when signing up to become this kind of doctor?
Good question. When you're in the middle of it, at least from my experience, I can't really think of, there was one rotation with an intensivist when I was a fellow, that was pretty rough. He wasn't the most pleasant. I never doubted it. I was just like, wow, this is not a good month. And then the second time around, we were, I stood up, I did the things that he liked to see, and he actually turned the heat on purpose, I come to find out. And then the second time, it was very, very pleasant, very good experience. Outside of that one rotation, no matter how bad it was, I think maybe one time, I was ending up a really sick end-stage liver disease patient came in. We needed to start resuscitating, intubate, put him on a ventilator, needed to get lines because he was hypotensive. And I remember it was like 2 or 3 in the morning, 4 in the morning, long night. I was up all night, and I ended up getting stuck with the needle, and this was a HIV hepatitis positive patient. And so that time, made me think about, wow, there's some risks, I just put, my life at risk, my loved ones, around me now potentially. And that time that I had to go through just, blood draws and prophylactic medication then for a month was miserable. But that was about the only time I can think of. Other than that, it sounds almost Pollyannic, but I enjoyed every ounce of training that I could get, that I was in.
Do you think doctors are ever expected to put themselves at risk as like sort of it comes with the job kind of thing?
There are, we try the best we can to mitigate this, with all various types of safety implementations, over the years that different specialties have noticed. but you're still going to be putting yourself at risk. Surgeons are knowing they're going to get stuck. They're going to get hurt, over the years doing what they do. That just goes with, the territory, and they accept that when they go for the emergency medicine. We know we're going to deal with, violent, patients at times, and we try and mitigate that with various security measures. So various specialties, yes, we do know there are going to be some risks. We do everything we can to try and avoid them, but there's really, and over the years, I think it has gotten a lot safer because we've learned from experiences in the past. But there's still, subspecialties, definitely, there's still some risk that we're going to have to be exposed to.
Mm-hmm. And so given the long hours, given the risk, what keeps you coming back every day when you wake up in the morning and you decide, okay, I want to keep doing this for the rest of my life?
Yeah. I feel like I have a purpose and I make a difference, especially with patients, one-on-one. See a patient, and if you see me as a doc, it's really not, you're not having a good day because you're coming to the ER or I'm seeing you in the ICU. And so you're either having a major surgery and you're recovering from that, or you're having complications of a major surgery and I'm treating you for that, up in the cardiovascular ICU. Or, most people don't come to the ED to get, hospital food and ice cream because, that's, they come because they're not having a great day for whatever is bringing them in. And so for being able to intervene, to see those patients, to make a difference, to, on their trajectory of their disease process, and also make a difference with their family and help their family along with it, because you don't really go through this in isolation. Family is, goes along with you, and so be able to do that. That's been every day. I feel like, it's worth it.
Mm-hmm. So now moving into what your life looks like as an attending physician, like what does your average day look like?
Yeah, for what I do, it's a little bit different. I did, because of the two specialties that I trained in, I'm actually practicing in both, which we're seeing more nowadays, which is good. It used to be we usually had to pick one or the other. Most of the people that did emergency medicine and critical care gravitated towards the critical care aspect of it. But there's more of us that are doing both. So, and being here at U of M, I came with the impression that research and education also are extremely valued and important, unlike maybe not as much as say in the community or other even academic type centers. And so my day when I'm working clinically in the emergency department, it's either starting off really early, 7 a.m. It could be a 8-hour shift in the ED, or it could be an overnight shift. It all depends. It could be an 8 p.m. to 8 a.m. shift over in our ED-based ICU. And it's a variety of different patients. Like tonight, the shift I'm going to go to, when we're done here with this interview, I'll basically be seeing patients, triaging them in the waiting room, trying to catch those patients we talked about earlier who are sick, and we can, treat them early and get them back and be seen rather than having them wait in the waiting room for just a routine bed to open up for them. Also to help, move the process along. And so that's what my night will be like tonight. I'll be working directly with a nurse, and I won't have a resident or any teaching responsibilities. It'll be very practical, very front-loaded, trying to kind of move the process, as quickly as we can. Other times that I'm working within the ED, I have a resident or two with me, depending on their level of training. I'll give them a lot of responsibility where I'm watching and seeing what they're doing, and they present. We come up with plans together, and we manage 30 or so patients a shift, that way. And so that's also very rewarding, but different. And then there are other shifts to where it's not quite as an acute, but there's still sick patients that are being mostly managed by physician assistants or nurse practitioners. And the experience that they bring, they can be very seasoned. I work with some, advanced practice providers who have 20 years experience and are very well seasoned, and we're more partners when we collaborate. And if they want to bounce something off me, a question that's more complex, we work together very, in a collaborative fashion. Some other ones who have started and they're very, fresh at this, it's a little bit more oversight, a lot like how the residencies would work. And so that's a whole different, almost like private practice type of spin to it. And so that's rewarding in a different way. When I'm rounding in the ICU, it's a week at a time. It's 12-hour shifts, and you're managing a large team of residents and fellows, or you're managing the advanced practice provider team. We have basically two teams, and these are primarily post-surgical cardiac, thoracic surgery patients, very complex. We have a complex cardiac surgery aortic program here, and so these patients are very sick, but some are just post-op and they're doing well. You get them through the first 24 hours and they go to the floor. So that variety of critical illness is also very rewarding too. That's the clinical part. The non-clinical part, I'm on several research projects that are going on. Again, very collaborative with neurosurgery, with, we have projects with dermatology, with pediatric, with emergency medicine, with critical care, and we're all various either clinical trials, or we're looking at various devices and ways to measure, bioengineering devices that, our bioengineers have come up with, and we, are taking them to the next step and seeing how they work in a clinical arena. And so that takes up a part of the time as well. And then there are other parts to where I'll be doing teaching with med students or residents or even fellows for that matter. And some of that's bedside teaching, which we do while we're on our clinical shifts, and other times it'll be more simulation teaching or more traditional, throw a couple PowerPoints up on the board type.
Excellent. So obviously your job is very multifaceted. What is the favorite part of your job?
That's like asking which one of your kids are your favorite kids.
Yeah.
It depends on the day. It depends on it. So if you do, what I found from my personality, if I end up doing one thing, for a period of time, it gets old, and the fun part of it, the enjoyment part, kind of gets a little bit tarnished. If you have several ER shifts in a row, the last few ones really, you kind of feel the weight of the pain that the patients are being put through, and then just the nature of emergency medicine nowadays with the weight, not getting anything done, patients can't move through the system because the hospital's full. That type of pressure really starts to weigh on you after a while, for me personally. And so by that time, usually I'm done and I have a few days off to where I can concentrate more on some of the research projects that I have or some teaching obligations. And then I move up to the ICU. And then that's a whole new different way of looking at things. It's a whole new set of problems. It's a whole new set of patients and docs and ways to approach critical illness. And that's fun, and that stays fun. After about a week, you're exhausted of working these pretty mentally and sometimes physically exhausting days. As you get a little bit more mature, 84 hours that week kind of adds up, and you're ready to be done with it. So I'm ready to be done after a week in the ICU. And then you have a few days off and you're back at it in the emergency department. So that variety really keeps all of it fun and interesting, and I'm looking forward. You always look forward to the transitions of moving into the new space. And even still after doing this for 20 plus years, that's still enjoyable.
Excellent. So when you're in the ER, what are some of the common pathophysiology that you see? Like what are patients coming in with?
Yeah, so here at U of M, we see a lot of complex patients that have common things that are added to their complexity. An example is you may have a kidney transplant, someone who's had 2 failed kidney transplants and they're on their 3rd now. And now they come in with a fever and hypotension and some confusion. And so not only does their kidney transplant now is struggling and you start seeing some failure in that, but also you have a patient that's in septic shock that you have to manage that. Or you see a very complex heart failure patient who now has a device in, and they're having problems with the device, and maybe they have been over diuresed and they need more volume. They start having low flows or whatever complication they're having with the LVAD device. Or you have someone who has stage 4 cancer, and they're having complications of their cancer, and it's now spilling over into some other organ systems, and they present, for this. That group of, say, complex patients would be the majority of the patients that we see, but each individual way that complexity presents itself is relatively unique. Rarely do we get a patient who has one pure disease process that's really acting up. Rarely do we get an isolated COPD or asthma flare-up without something else that they have that's also being affected. The same way with heart failure. Very seldom do we see just a heart failure flare-up without something else being associated with it. Say that's a heart failure, but that was a heart transplant patient, or that's a patient has a device in place, etc. Which makes it takes it to the next level of what you would see in a more of a community-based emergency department. The trauma that we have here is different than the trauma that I worked in, bigger inner cities before. I worked in Detroit and Richmond, Pittsburgh. A lot more penetrating trauma in those cities. Here we see a lot more blunt, a lot of motor vehicle crashes, or traumas that get flown in from other smaller emergency departments that we then are the definitive care for them.
Would you say that the burden of disease that you see is equally shared amongst the population? Or would you say that there are certain patients that are just more likely to suffer certain things and certain patients that will never see that?
Again, that's a good question. It's hard to make population-based assumptions here at U of M, because we end up getting all of the complex patients that are referred to all the small communities that have various access to, say, primary care or even specialists, as compared to someone who lives in the local Ann Arbor area. So it's hard to say if we're seeing more, population-based disease burden that can be teased out, because here it's such a skewed population to begin with that we see in the, at the U.
And so in terms of when you're assessing a patient, what are the most important tools in your diagnostic toolbox when you're trying to figure out what's going on?
Good question. Again, over time, and with the training, you get a sense of when you walk into the room or the resuscitation bay, and just the first 15 seconds that you're seeing the patient and how they're behaving and how they're interacting, and you can get a pretty good indication, is this something that I need to act on immediately right now to do a life-saving intervention? Is this something that it's going to go south pretty quickly, so I need to act within the next 5 to 10 minutes? Or is this something that I have a little bit of time that we can get, we have the luxury of maybe getting some lab work back or some studies back before I get some consultants, or I get, some other, more focused ways of managing what their problem is. And so I think that's probably that acumen that you just, from experience, is probably the most, the most utilized, and I think most important. Now our trainees are becoming very facile in all kinds of modalities. Ultrasound has just taken over in the whole field of medicine in the last 15 years, especially emergency medicine and even critical care. And so our trainees are just phenomenal with the ultrasound machine. So from an actual, say, gadget, where I was trained with stethoscope and using landmarks and, percussion, techniques and how to feel for if organs are enlarged. They grab an ultrasound now and very quickly can quantify that, and and can look at the liver, can look at the heart, can look at the kidneys, and they can tell things very definitively and very accurately within a matter of minutes, which is also very helpful. Speeds up process, speeds up diagnosis, speeds up treatment. I wish I could say I was even half as good as a lot of my residents that have come through here. But that's something I've seen definitely evolve to where we really were trained in nothing as a student, there was still a clinical or a trial going on that was very cutting edge of using ultrasound in trauma patients, and now it's standard of care. Level 1 trauma center using a ultrasound fast exam is standard of care for that. So it's really evolved very, very quickly.
So nowadays there's been this rise of physician burnout, right? A lot of times physicians are feeling sort of disenfranchised by the system. How do you go about mitigating that in your personal life, and from like a systems approach, how do we fix that so physicians who are sort of putting themselves at risk to take care of other people aren't feeling that intense pressure themselves?
Yeah, if I knew the answer to that, I wouldn't be sitting here right now. I'd be going on the lecture tour, providing that cure for us. I don't know a good answer for that. That's something that we all have to struggle with, and I feel burnout at times. I feel it's a lot more. Don't have as much energy and drive to do a lot of the things when I was younger in my career. Just did it on my own time. I think that also can be, as you touched on this earlier with one of your questions, to where do we just have to sacrifice? And how much do we sacrifice? I think that's the key is how much do you sacrifice? And unfortunately, you learn that, at least in my generation, you learn that later in your career. And so by that time, a lot of the sacrifices are, that's unmitigatable anymore. It's gone, and they've been sacrificed. And so the best that we can do is pass this down to say, there is no such thing as work-life balance. It's work-life imbalance. There will be imbalance. The question you have to answer is, how will that be imbalanced? To what level will you accept not progressing like you would have liked? And that can either be on the career side or that can be on the family side. And that's something, unfortunately, that's a choice I think a lot of us, even outside of medicine, that are very, climbing up in your career, has to make. But there's no, the fallacy of being a perfect balance just, doesn't exist. It might exist for a small part of the time, but throughout your career, it's very, very difficult to have even small pieces of time where you feel like your life is in balance from that. So as far as burnout, I think physicians and even healthcare providers over the years have just feel disenfranchised. Feel like our voices haven't really been heard. To administrators, to hospital systems, to lawmakers. When more and more is asked of the healthcare system without providing resources. I think ultimately it's gotten to be such a huge endeavor and profession, the healthcare profession, that isn't very small amount of it is directly patient related. That we just feel like we're such a small piece in this puzzle now that decisions are going to be made that we don't have as much control like we used to.
And I'm sure, like, if I ask this question to different people, I'll get different answers. But given this sort of sacrifice you have to make, would you say that medicine is still worth pursuing in this day and age?
So worth is the key word, and that's going to come individually of what you find worth and value, and it's going to be based on your own individual value system. If you look at worth as a financial investment, that's going to be variable. Your return on investment, if it's just purely financial, that's going to be influenced by a lot. If you're coming, I'll just use myself. Med school and college tuition was nothing near what it is today. I think at the end when I was done, I was able to pay off all my loans in about 3 years. Wow. And I grew up on a wheat farm in the middle of Kansas. We were, we were not, and we didn't own Cargill. It was a very small little operation. It was, very humble, upbringings, but it just wasn't that expensive as compared to nowadays. So if you have somebody similar that doesn't get a lot of scholarships and has to pay retail price for their education and then their training and then working, the 80 hours a week for 3 to 7 years, depending on what you go into, and getting paid, roughly around $6 an hour doing this, you may not have a return on investment that other professions may value. However, if your value system isn't necessarily based in that, and it needs to be based financially, because you need to be able to at least take care of yourself and your family. But if your value system is based in other ways of helping others, and you really find meaning and purpose in that, then I definitely, it's worth it. Do you have to be a physician to still fulfill that value-based system that individually you may have? That's a good question, and you may not need to be a physician. There are a lot of other ways now, a lot more popular than they were back when I went through training, such as being advanced practice providers, not as long as training as I did. Nursing is not as long, and you can still have great rewards of dealing with your patients and have all kinds of career opportunities within the health system and outside of it, entrepreneurship along that line as well too. So you don't necessarily have to be a physician. I find great worth in it. I found the value of it today. I wouldn't go back and change a thing. But if I had to come out and look at the financial investment that it takes, starting now, where I was at the time, I would really have to think hard about if I could even do it from that standpoint.
And so if you sort of spelled this out already, but if you were to give some advice to someone who is considering a career in medicine, what would you tell them?
Well, first of all, I'd just ask them why. Why do you want to be a physician? I'm assuming you say career in medicine, I'm assuming you mean physician, because there are a lot of other careers.
Correct, yeah.
So, why do you want to be a physician? What part of it, are you attracted to? Have you looked at non-physician roles, and do they supply the same type of, value or worth that you find important in your, in how you see your career growing? Because some of those may actually allow you to, get closer to that life, profession balance, work-life balance that we talked about earlier. And, I think a lot of people are really hard, considering that question now and are not going into, the physician route and taking other routes with that. But that'd be where we'd start. And then we just have a conversation similar to how we're having this one, about, the path that you will be going down, to get here.
Excellent. Well, Dr. Gunnerson, thank you so much for your time. I really appreciate you. And, anyone who's interested in medicine, check this guy out. He clearly knows what's going on. But yeah, thank you so much.
All right, thank you. I appreciate it.